And our next speaker is Tom Frusher, who joined McKesson in the summer of 2012 as Director of Policy and Corporate Affairs, responsible for matters across UK markets and in Europe. He's worked closely with a wide range of integrated care providers in the US and has also held a number of senior posts centred on health reform in the UK. And his title for us today is The Chicken or the Egg, the Role of IT in Achieving Integrated Care, Lessons from the US and UK. Tom.
Thank you, and thank you for taking a moment out of your time here at HC 2013 to come and listen to me. I'm obviously very pleased to be following what appears to have been a barnstormer of a presentation, so now I have to live up to that standard. As was said, I'm Tom Frusher. I work for McKesson. McKesson are a provider of IT services and solutions to the NHS and to the social care sector. We've got a long-standing relationship in the UK with providers of care across the health and social care spectrum, and we're very proud of that. What I'd like to do in the next 10 or 15 minutes is share with you some of the key issues from my perspective in respect of the role that information technology can play in the delivery of better integrated care. Without getting too much in amongst the weeds and defining integrated care, as that's always something which comes up. I mean, I'm very much talking about care which is better coordinated, that achieves better outcomes for patients and delivers improvements in efficiencies for the organisations delivering that care. In large part, I will draw on experiences and perspectives from the US, and I know that normally inspires a few groans. There are things to learn from there, both good and bad. And I will do so and highlight the challenges that we face in terms of exploiting what can be the potential benefits of information technology in the reform of care delivery. And throughout the talk, I'll try and reflect on what some of these lessons might be for the UK. I should probably stress now that what I intend to say are really my views and not those of McKesson, just in order that I don't get anyone into trouble. So, to frame the issues, I think we can perhaps start really with the grand context. So obviously on both sides of the Atlantic, there's recently been quite heavily contested large-scale reform programs. But a key pillar of reform on both sides of the Atlantic has been very much around improved integration and greater coordination in collaborative arrangements amongst providers to deliver care. In the US, the Patient Protection and Affordable Care Act, or Obamacare, which probably had only possibly just a little bit more of a fraught passage than our own Health and Social Care Act here, had contained within it plans for accountable care organisations, which I'll come on to momentarily. Whilst in the UK we had the Health and Social Care Act, Health and Social Care Bill, which had a laser-like focus on the integration of health and social care. Very briefly, what are accountable care organisations? Well, they were developed really as a federal concept, so a kind of top-down concept by the Centres of Medicare and Medicaid, and they were very much around trying to catalyse delivery system reform. There was a tiny slice of financial or payment reform in there because there's gain-sharing arrangements, but largely it was about trying to get otherwise independent providers to better coordinate care for a defined population, promoting evidence-based medicine, and probably most importantly, reporting on quality measures and outcome measures and financial measures back to CMS, where those people were involved in the federally mandated programs. Of course, the private payors and private sector in the US followed that model quite closely, and so accountable care organisations aren't just there for the provision of Medicare and Medicaid, but commercial insurers are entering into arrangements with providers in the US to have accountable care-like organisations as well. And I think currently there's about 400 provider organisations now who are terming themselves as being accountable care organisations. I think of those, less than 5% are actually taking any downside risk. It's all about gain sharing on the side of the providers, which I think raises issues, but that's not for today. So both reform programs were equally assertive in terms of their push for integrated care, better integrated care, but at the same time both were informed by sizable commitments or views on the benefits that information technology might bring to bear. In the US, this kind of predated Obamacare. They had the High-Tech Recovery Act, which pumped billions of dollars into the US economy in various areas, one of which was around healthcare IT. And they then developed the concept of meaningful use, which put out a series of markers about if you're using healthcare information technology, if you use it in an intelligent way, you'll begin to become able to draw down on some reserves provided by the federal government. In the UK, obviously following the hot potato of MP Fit and the perceived failure of the Connecting for Health programme, and if anyone saw the PAC meeting yesterday where the people from the DH, including David Nicholson, were being grilled still about the Connecting for Health programme, that one is not going anywhere anytime soon. But obviously now we have a very engaged Secretary of State who wants an NHS revolution in terms of information technology, and we have NHS England and Tim Kelsey, who again are very, very keen to foster an environment in which technology is brought to bear for patients and providers. My insight into the current US reforms came courtesy of the Commonwealth Fund of New York, who you may or may not be aware of, a well-respected think tank in the States who do great work. I'm not beholden to plug them, but I feel I must because they do great work, and it was only at their expense that I was able to do this. So I'd say check out their website and the opportunities they afford for people like yourselves to go to America for a year and have a great time. So during my year in the US, these are just a small selection of the people that I pestered and bothered and spent time with to learn about either what they were doing on the ground as providers, talking to their clinicians, chief medical officers, chief financial officers, and talking to the people in the federal programs, everything from CMS through to the Department of Justice, who were involved in reform issues. So what did this mean in terms of my arriving in the States and my immediate experience of the healthcare and information technology nexus? So I arrived in Philadelphia and I very quickly got hungry, and so I phoned up my local pizza shop. They were very courteous, as were Penn Medicine on my first call when I said I'd like to register please for a GP. And after going through a few iterations explaining they didn't know what a GP was, I said I'd like a primary care physician, a family physician. They were very friendly too at Penn Medicine, but they said, no, I'm sorry, you've not got the relevant information at this time, please can you call back? I gave them quite a lot of information, but it wasn't enough to progress further. On my second call to Powelton Pizza, they knew my name, knew my address from my telephone number, my unique identifier, and they asked if they could take my credit card details and they'd store them, and I said, that sounds like a great idea. And again, the pizza was very nice. So on my third call to Powelton Pizza, they knew my name, they had my credit card details, they knew what pizza I even liked. Oh, the same as last time, that's fine. They even asked, would you like it cut the way you asked the time before? I think it was 8 weeks later I had my first appointment at Penn Medicine, having had several phone calls, and when I arrived on the day I filled out forms which appeared to be the same information I'd given in 6 subsequent phone calls before that point. So what does that where does that leave us? Well, I used that experience as a kind of way into these conversations with the people I showed you on the slide. Why is this happening? You see guys seem to have a lot of money, there's a lot of shiny buildings, there's a lot of feeling that America has the best healthcare in the world, which it doesn't generally speaking, but they felt that. Why is it that you haven't managed to kind of use IT in an intelligent way? And the answer was, unsurprisingly, it's expensive, it's hard to use, it's difficult to maintain, the doctors don't like it because it disrupts their clinical practice, it's expensive, there's no return on investment, and we think it gets in the way of the doctor-patient interaction. So that was a couple of years ago. Where are we today? This report came out just a few days ago by the Commonwealth Fund, or by one of their main researchers, another plug. And this kind of shows where they are now, probably 2 years later than the day I arrived on US soil. And there has been a slow uptake. So now we're at about 40% of US physicians have adopted what they would regard as a basic electronic healthcare record. So there's been slow and continued progress as people are trying to leverage IT and use that data in order to manage the health of their populations. So 40% have a basic healthcare record. Another 10% have almost achieved level 1 and a bit of meaningful use. So this is what they're using the medical records for. None of that is particularly surprising, maybe. But should we be surprised at what appears to be a pretty low take-up even today? Well, I think they're on a series of change curves in the States whereby they're now going through a process of adopting IT, and then another change curve is using it intelligently. And they're now starting to spend money and buy new systems, but they're not necessarily using it in a kind of value-added way. But it does appear they are moving towards a tipping point where maybe half of practicing physicians are starting to use IT intelligently. And I think it's interesting in that context to reflect on the UK and what's happening here. I don't know how many of you were around yesterday to hear Beverly Bryant and NHS England announce e-referrals and so on, and some of their other initiatives as well, where they're very keen not to mandate these kind of initiatives and push them on people. What they want to reach is a tipping point where your average GP or hospital or care provider feels it would be remiss of them not to have this particular bit of kit or be using IT in a particular way. Perhaps that it's just simply not professionally acceptable not to be using tools that are available to you. Just before digging down a little bit further into the particular issues around information technology and integrated care in the US, it's worth just pausing for a moment to just explain some of the attitudes to integrated care generally in the US. I've spent 10 years with a kind of policy wonks hat on, watching the conversation go around the houses in this country, people talking about the need for better integrated care, citing in many instances the exemplars in the US. So now with a real focus in terms of healthcare reform and integration, these are the kind of things that I would come across. There'd be those people very, very keen indeed, largely the people that are already in an integrated care system who thought it was a great idea. Some pragmatism, the people that understand actually there does appear to be real benefits from having that continuity of care and ensuring seamless transactions in terms of healthcare. Cynicism, yes, much of that. People didn't really like ACOs. They often don't like the government forcing things upon them in the US, even more so than here. And so ACOs, another consulting opportunity, people scared that they were going to be moving back towards health maintenance organisations, and people feeling that the system just was not going to be able to integrate because it's fundamentally broken, and so putting wings on cars and calling them aeroplanes. And I think a lesson for the UK is that if you've seen one clinical integration programme, I caught the last half of the presentation, then you've seen just one of them. Take some principles, but that's not going to work necessarily for you in your location. So overall, I'd say that even those that are advocating the use of IT, I've been pretty much cowed by some of those statistics I showed you, which shows that there really is sluggish adoption. Systems are not interoperable, they're not intuitive, and there's really a failure to marry your shiny new IT system with changes in clinical practice. So let's look a little bit more at that. But before we do, very briefly, so the barriers in terms of integrated care, as I came across them in the US, and as you'll see as you read the literature, really are very much internal. I know we get quite caught up in what are the policy initiatives and the regulation and so on, but actually it is about those cliches of leadership and culture, having physician alignment, having doctors on board. External barriers in the States, regulation, particularly HIPAA, which is to do with privacy arrangements, which really does cut across the IT discussion. And there's something here I know as patient records are made accessible online and people have access to the information. Privacy, confidentiality and consent issues will be at the top of people's agendas here. And the general stranglehold of federal, as they would refer it to, and as what we would see as top-down initiatives. But interestingly, and digressing slightly from today's main theme, is what they actually felt. The most difficult thing were the patients. The quote at the bottom, I won't say who did that, but they were a medically qualified care provider who felt that patients were just generally difficult, and why do I want to put myself at risk, that is financially, for these people who are just generally non-compliant. But over and above that, it was actually about educating and informing patients. In terms of ACOs, you were assigned your ACOs, patients. You were told this person is in your ACO, but you had no control over that patient. They weren't locked into your healthcare system as they were in the days of HMOs. So you could be managing their diabetes absolutely fantastically, but they could, on any given Tuesday, decide to visit one of your competitors or providers down the road get charged 5 times what you would be expecting to spend on their diabetic care, and you go at risk at that. So that ability not to be able to keep patients within your accountable care organisation was a real bone of contention. So as I said, just digging down a bit further into some of the issues, particularly related to the IT. Well, the sluggish adoption, I mean, the issue there is that a lot of people get very scared about investing in information technology. You'll all have heard of the Kaisers, who spent 4 or 5 billion pounds on its information technology system. You've heard of the VA, Veterans Administration, who built up their IT system over years, and Intermountain, who have a all singing, all dancing thing. But some of these ACOs are very small. I visited ACOs with just a couple of doctors looking after their patients in the backwaters of the US, and they did require IT in order to deliver some of the requirements and just generally to manage care in a better way. But they didn't want to jump. They didn't have the money to spend. They were worried about technology not only becoming obsolete, but regulations changing and so on and so forth. In terms of interoperability, I mean, it's a really hot issue wherever you go in terms of information technology now. In the US, I think there is a growing sense, and there is now some very kind of high status alliances trying to drive interoperability across what is a very fragmented system. But they've reached a stage where your healthcare record, well, you don't have an ATM card situation where you can just go plug in and get your access to the right information, the right data, wherever you want. You actually have more like a store card approach, whereby your provider will have a great IT system and your data is all on there. But if you go to another provider because you're out of town, or you just want to join a different provider who's actually down the road, that data cannot be transferred. So even someone, again, like Kaiser or so on, they have very rich data about you, but you could go to a hospital half a mile down the road that's not a Kaiser hospital, and that data is not available. And that's something which, in terms of integrated care, is not a great starting point. Data, systems not capturing the data that you require. I think this is an interesting one now in terms of where we're going in the UK. So in America, they have the ACOs are being asked to report on certain quality metrics. If your IT system doesn't really capture those quality metrics, then what are you supposed to do? And I think as requirements here from whether it be NHS England, CCGs, regulators, and patients themselves, does the technology that we have support that kind of capture of data and then changing that data into valuable information? Bandwidth, I guess that's kind of an obvious one that you'll all be well aware of. There was just a lot going on in the American healthcare system, as there is in the UK one. And yes, IT would be nice, and better IT would be even better. But right now, I'm trying to just make sure my organisation stays afloat. And there's, the risk of taking your eye off the ball because of an IT implementation was all too obvious to the people there delivering care. And obviously in the UK, with all the changes wrought by the Health and Social Care Bill and the ongoing financial challenge, people's nervousness around the consequences of the Francis report, going to your board and saying we really would like to implement a new IT system, we think it's going to bring real benefits at some point in the future, is not necessarily going to be at the top of people's lists. So having that evidence, having an evidence base where you can demonstrably show the benefits of a stepwise change in terms of implementing new IT is absolutely essential to get people on board. But I think people have often struggled to find that evidence base in a way which is persuasive and cogent. Physician and organisational resistance, I guess that quote I showed you a few moments ago goes some way to explaining that. There is some professional inertia, and I think we see it as well in the UK where, for instance, in general practice, people have been busy over the years developing, in many instances, quite good information technology architectures. And for people to come on board and say, we'd now like to kind of integrate, use your systems or change your systems, people can get very protective having invested time and energy in getting to where they are. And I think there is, again, going back to the evidence base or lack of, in some instances, people are worried about IT being a bit of a drag on efficiency. And speaking to many people, both in the US and the UK, they felt, particularly in the early days, that actually it did put up a barrier in terms of their efficient workflow and so on. And we can come back to that later. And finally, patient engagement. I think it's absolutely right that we should be looking to support better care for patients, better transparency, better access to people's medical records. And we see that very much at the moment, obviously, with NHS England pushing in that direction. But you can take many surveys in the US, for example, where you'll regularly get plus 90% of patients and citizens saying we want access to our medical records. But there was a new study, quite a large one, came out recently, that reflected on that, but then showed that they went to and did a sizable survey of people who were offered the chance to have access to online medical records. Of those, 42% actually signed up in a 2-year period, and of that 42%, I think less than half accessed them more than once in the 2-year period. And so there's a bit of a reality gap there sometimes between what we're saying we want to deliver for our patients and doctors and what actually will be used in a value-add way. I think the kicker to that story is that within that survey, the people that actually did use their records more, there was a direct correlation between the number of comorbidities they had. So I think if we're looking at how can we better use IT to deliver for people with long-term conditions and chronic conditions, they are the ones actually that will probably use IT in a more intelligent way if it's available to them. Okay. But with all that said, where are we now? Well, in the US, there are now more doctors using EHRs and more organisations investing in IT and using them in more advanced ways in order to ensure continuity of care and better transitions of care and so on. But at the same time, unfortunately, people are becoming unhappier. And whether that is as a result of some of the issues that I've raised, or is it because people's expectations are going up? If you see over this 2-year period where money was flowing in terms of people being supported to deliver better IT and with a kind of consensus that there was a need for change generally in the healthcare system, I think it nearly doubled. That's right. The very dissatisfied group did double over that period. And so this raises further questions, and I guess for myself and people in the industry, in the IT supplier industry, that raises some real challenges to us in terms of how we take forward that partnership approach when people are voicing their unhappiness. So I'm not sure how I'm doing for time. Fine. Okay, I'll just go through to... So in conclusion, back to my pizza story, it's absolutely essential that managing the challenges is all about delivering innovation at a pace that could be consumed. I think the concern is that everybody intuitively says, well, as more technology comes online, yes, we should be using it as intelligent as we can. We should be getting that onto the front line as quickly as we can in order to deliver benefits. But there has to be, there is a delicate balancing act in doing that, and that we need to work in partnership. When I say we, I think I'm talking about, for instance, the industry, with our customers in terms of how we better approach that, managing the difference between you have complex operational concerns when you're running your hospital, your GP practice, your district nursing organisation. We want to give you some technology which we think will help you, but how can we go about that in an intelligent way that won't disrupt your practice and will deliver sustainable improvements for patients? Anecdotally now, as I've been here on board for about a year at McKesson, I mean, clearly having clinical leadership from the outset is really important. When we go into organisations, we now want to talk to the clinicians from day one. That's not something you do later down the line where you've ticked all the boxes. And we've seen that particularly with some of our smaller stuff around Coordinate My Care, where we've worked very closely with the Royal Marsden to deliver this end-of-life care record, which is now going out across London. And that's where you have physicians who are very invested in that particular service have told us what it is they require, exactly specify what they need, and that's really is delivering for patients and that organisation in terms of outcomes and efficiencies. And that all is about, as I think I've just mentioned it, about a partnership approach, that when we talk about IT enabling exciting changes to care, it's not just about dumping people with a shiny black box and saying, right, there's the tools, off you go. It's a long-term partnership in order to ensure that what you're providing delivers sustainable change. And as I think I'm out of time, I'll stop on that note.
Thanks very much, Tom. We do have time for one or two questions. Any hands going up? Yes, the gentleman down there.
Thanks, Tom. So it seems that there is evidence that greater use of IT will bring benefits for patients, will help physicians improve their care. But on the cost side, costs are obviously also extremely high. So whilst there may be benefits, there are also huge additional costs, which then raise the question of, are we actually talking about cost-effective interventions here? And is there a way to sort of sequence the implementation to ensure that we do it in cost-effective steps? Do you have any evidence or views on that you can share with us?
I think the sentiments that you express, I agree with you. I think I talked about the evidence base, and in many respects that's often thin on the ground in terms of the benefits. Intuitively, it's all there, and I think at a basic level, the idea that information is accessible at different points in a geography or different points in time to a range of providers or caregivers just makes sense. Then you ask the question, well, how much is that going to cost, and just how much sense does it make? And I think back to the evidence base, it's not that it... Is all of this a bit of a stab in the dark? I don't think so, and I really hope not. But actually, you're right. At what stage can we really start to demonstrate the value, the ROI, however you want to put it, both to patients and to a system in a way which means that people will be confident? I talked about the sluggish adoption, and it's people just being reticent about investing, almost putting their eggs all in one basket, and then finding out that they put them in the wrong basket, or in fact none of those baskets were where their eggs should be. But I don't have a definitive answer to say that. I mean, that is one of the ambiguities that I think faces people today.
Thanks, Tom. Any more questions? In which case, I'll thank both our speakers again and wish you all a happy lunch.